Hi, I'm Christine, and this is my adult case presentation. So my client is JC. He is a 76-year-old male who lives at home in Port Jefferson, and now he resides in long-term care at St. James Rehab and Healthcare Facility on the east end of Long Island. He lives alone and has 3 daughters and 1 son who all live in New York, and he is a retired construction worker and actively volunteered at an animal shelter. So according to JC's case history and medical records, he has a history of hypertension or high blood pressure, has a history of heavy alcohol consumption. He experienced 2 transient ischemic attacks in March and September of 2017, and as a result was hospitalized and then previously admitted to St. James Rehab, where he received short-term care services for dysphagia and aphasia. The medication he takes include sertraline for anxiety and depression, losartan for his blood pressure, phenoprofen, which is a non-steroidal anti-inflammatory pill, and capsaicin, which is a topical cream, and this and the phenoprofen are both used to treat his nerve pain and pressure sores that he gets as a result of being in a wheelchair. So he was admitted to St. James Rehab and Healthcare Center, which is a skilled nursing facility, in April of 2019 following hospitalization due to an ischemic stroke. His discharge report from Stony Brook University Hospital indicated a change in his mental status. So these are his primary diagnoses with their associated ICD-10 codes, and as you can see, aphasia following cerebral infarction is his primary diagnosis, and he has a secondary diagnosis of oropharyngeal dysphagia. His general plan of care for speech-language therapy includes speech, language, and dysphagia treatment for 45-minute sessions 4 times a week, 3 sessions of which are individual sessions and 1 of which is a group session. So now I'll briefly talk about the plan of care to address the aphasia. According to the SLP notes in his records, the observations include impaired confrontation naming or anomia, awareness and frustration with his errors, occasional trailing off during spontaneous speech, occasional confusion during conversation, sporadic circumlocutions, and comprehension within functional limits. When I observed him for the first few times, my observations were basically mostly the same, except I also observed a slow speech rate, reduced loudness, occasional circumlocutions, appropriate topic maintenance, he was completely alert and attentive, he was very socially engaged and cognitively aware. He was aware of his impairments and also showed frustration behaviors with them, and he had completely intact language comprehension. So his treatment goals for the aphasia, his long-term goal, resident will improve verbal expression skills to facilitate increased participation in daily tasks and improve overall quality of life. And the associated short-term goals, resident will demonstrate appropriate use of word-finding strategies with 80% accuracy and minimum to moderate verbal cues to improve expressive language skills. So this one I would just make this more specific by changing demonstrate to complete confrontation naming tasks with visual cues, because it's more specific and more measurable. And the second short-term goal, the resident will complete short sentence and phrase completion tasks with 80% accuracy and minimum to moderate cues. So this one needs to also be more specific, including the types of sentences, phrases that we'll be targeting in the completion tasks, and what types of cues we'll be giving him, because it just says cues. So, does it include verbal cues, visual cues? So this slide just shows the G codes with their modifiers and the associated impairment level according to ASHA's National Outcome Data System, based on the domain of spoken language expression. So in this domain, JC is considered to be at least 20% impaired, but less than 40% impaired, limited, or restricted. So his language interventions, included semantic feature analysis with multiple modalities and cueing hierarchy. For semantic feature analysis, I created my own chart using a large font and large pictures because he told me early on that he couldn't read print that was too small. So I used confrontation naming tasks, starting with pictures of more common items that I knew he'd be more familiar with so that he could get accustomed to the procedure, since it was kind of complex to answer all of those questions for one item. For each picture I showed him, we answered each question regarding its properties. So as you can see from the example semantic feature analysis chart on the right, you can see all the different kinds of questions that are included in this treatment. I also incorporated gestures and drawing into his word finding treatment. I would ask him to recall something, for example, what he had for breakfast. So if he had cereal, if he responded cereal, I would ask him, "Oh, what kind of cereal?" And if he had difficulty thinking of the name of it, I would sometimes ask him to draw it for me or show me using gestures, kind of mimic what it looked like in terms of its size and shape. I would also ask him to describe it for me using the aspects of the semantic feature analysis chart. So the size and color of the box, if the cereal was shaped like an O or if it was flat like a flake, etc. I also used a cueing hierarchy, so if he was having word finding trouble, I might first cue him with its function. So for example, you use it to do this, and then move on to more supportive cues if he needed it. He often thought of the word once I gave him a rhyming cue, but occasionally he needed a sentence completion cue. So now I'll go over the plan of care for his dysphagia. My observations during mealtime included, that he self-administered fine chopped solids and thin liquids via straw. He coughed after swallow on 3 occasions. He took extremely large bites, and he easily followed prompts for successive dry swallows and bolus size modifications. His voice quality was within functional limits following a successive swallow. And also he frequently talked and laughed while chewing, which could have contributed to him possibly coughing or choking on his food. And his oral sensation appeared to be within functional limits since he independently monitored his oral residue. His treatment goals for his dysphagia. His long-term goal was resident will safely and efficiently consume the least restrictive diet with 80% accuracy given minimal cues. The associated short-term goals. The first one, resident will consume fine chopped solids and thin liquids without overt signs and symptoms of aspiration with 80% accuracy and minimal cues. The second one, resident will self-monitor use of safe swallowing strategies, alternating solids and liquids, smaller bites, etc., to optimize safety of oral intake with 80% accuracy and minimal cues. The third short-term goal, resident will complete oral motor exercises and to increase labial and lingual range of motion with 80% accuracy and minimal cues. So I think these goals definitely are functional for him and target his needed areas, but just for this third short-term goal, I thought I would have specified which type of cue that we were giving him, so verbal, visual, or tactile. So the intervention for his dysphagia involved behavioral strategies such as modifying his bolus size, alternating solids and liquids, pacing strategies such as telling him to put down a utensil after he takes a bite, chewing and then swallowing completely before taking the next bite, as well as verbal cueing. So we also did oral motor exercises, including lingual resistance and labial range of motion exercises, as well as tactile stimulation with a tongue depressor if he had trouble imitating the exercise based on its picture. And here are just the G codes with the modifiers and the Ashe-Noms levels for his dysphagia. And just like his spoken language expression G codes, his impairment level was between 20% and 40%. That's it. Thank you.